Good morning. Welcome to our monthly webcast. I'm your moderator Samir Mehta. This is session number 86. We continue where we left last month with the focused BVS training sessions. Today we have for you a dedicated bifurcation lesion where you learn the tips and tricks that may be required for appropriately deploying a BVS in these lesions. We also have an enhanced feature for you today. There is a dedicated YouTube channel for your enhanced viewing, and hopefully that you will find it very useful. With this, let me take you to the cardiac catheterization laboratory where Dr. Sharma and Dr. Kinney are standing by.
All right.
Samin, good morning. Here we go. 2 months ago we started YouTube. Now we have a dedicated YouTube channel.
Wow. That's fantastic.
And they need to go to the YouTube channel, CCC Live Cases, put in Dr. Samin Sharma, and you can watch live with much better visibility. Anu, good morning.
Good morning.
Let's train the world and let them know how best to use a BVS.
Yes. And clearly welcome to all our viewers. And now you can see the calcific lesion that before I always say that calcific lesion looks that on your low magnification as if when you are doing a ventriculogram and before giving the dye, and it's a very calcific LAD, and we are ready to take a picture and I'll go through the case.
Is that a 7 French guide?
It's a 7 French guide,
okay.
Yes.
All right.
Yeah. So now, this particular case we'll go through. Let's take one more picture.
Samin, from last time's question, there were several feedbacks. One of them is the most pertinent. The viewers want you to explain better how the markers are located on the BVS.
Right. Good. Okay, so this is the case for today. So if we can quickly, as you can see, the LAD very calcific, spans from proximal to mid LAD, and then there is a significant disease in the diagonal, which is about 2.75 millimeter vessel. So it's not a small diagonal, very angulated, shallow angle. So angle basically some people define at level of 70, some say 90. So clearly the angle is barely 45 to 50. It's a shallow angle of the diagonal, not a T exactly the 90 degree. So and then you have a lesion from the proximal to the mid LAD, moderate to severe calcium. The diagonal seems not to be calcified, but clearly it's the Medina 111 lesion, and this is where we felt that we are going to go after that in this particular case, try to use, because of calcium, better expansion of the stent by using a rotational atherectomy, and then go with a 2-stent strategy. Should it be a 2 BVS or should be the metal DES in the side branch and the BVS in the main vessel, and this is what will be the part of our discussion will be, and I'll show you the data, and then of course when we perform we'll have a lot of input. So with that note, first if we can go to our slides, clearly our this webcast supporters right there, the disclosures no change, and this is a 64-year-old the female patient with the class 3 angina and CTA, revealing significant calcific LAD. I'm sorry for this typo that we had to change it to a female. And the patient has cardiac cath on August 2nd, which revealed 2-vessel disease of the LAD diagonal calcific, which we showed, and then Ramus, and had a stent in the Ramus. You want to show the stent of the Ramus, which is completely fine. Which
yes,
we have
looks
shown.
very nice.
Yeah, very nice stent. And the patient was put on medical therapy, still had angina.
Samin, is that a Zynes there?
Yeah, it was
Promus.
a
Promus.
It was a Promus
Okay,
Premier.
all right, yeah.
The 30 16 millimeter.
Got it.
So as you can see, the basically today syntax score was 21. If we take the Ramus syntax of 3 out, now it's a syntax of 18. And today our plan is the calcific LAD-D1 bifurcation using rotational atherectomy and absorb BVS in the LAD and metal DES in the D1. Now you will say why, because then I'll share with you various the data which we have which come up in the literature on that aspect. So basically, because of the proximal LAD lesion, it's appropriate, although patient did not have any functional study but symptomatic, and the CTA showing significant lesion, and of course we see it here. The while we are getting ready to do the rotational atherectomy of the LAD with the 1.5 or 1.75 bar? 1.5 bar, and then we'll do the OCT that we have been doing. And meanwhile, I'll talk about these two important points, which is the absorbed BVS in the bifurcation lesion and the impact of FFR value post PCI. Now, as you see there, clearly the usual technique, whether one stent or two stent techniques, which have been done with a metal DES, because we can cross over, do a crush, and so may not be applicable to the BVS technology. And clearly that usual our issues of the crush particularly and culotte, that you are going to a double layer stent may not be possible because the strut thickness is 150 micron. So that is the key. So very thick strut, and clearly that if you try to do overlap, you are going to decrease the lumen, which is 0.14 millimeter or 1.5, and times 2 may always becomes almost 0.3 occlusion. So what I put it here is the positive and negative of the BVS in bifurcation lesion. Positive is absorb in 2 to 4 years, restoration of endothelial function, positive vessel remodeling, better apposition of carina, disappearance of the strut on the side branch ostium and the carina. That is the key. So even if you have a little strut on the side branch, it doesn't cause problem acutely. On long term, it will do better because that strut will disappear and reduce risk of very late events. And this, of course, particularly thrombosis, and which we need to still see, because we don't have a very long term data, which we knew with the metal DES after 1 year, you continue to have 1.8 to 2% event per year. Are we going to decrease it with the scaffold? We need to see. Now, negatives are greater strut thickness, which we know 150 micron, and also it's a width. It's not only thick, so vertical and horizontal, both thickness, and then bulky device, difficult delivery, possible strut disruption. If you go to high pressure, you can disrupt the strut of the BVS, and the difficulty in side branch wiring. And if you can wire it then even advancing your BVS or DES to the side branch, which we routinely do. We go through the strut, we open it up with a high pressure, and then you put your DES to the side branch. This may be difficult because the ostium we can open up the side branch strut before, if in case you need to do a provisional stenting, and later on you have to put a stent after the stent of the main vessel.
Samin, to me this is the real slide and the take home message for the entire case. Can I provide my own observation and summary on this, and then want you to confirm it, that really it is going to be technically you need to get it exactly right, and if you are able to do it long term, you will be probably much better off. Is that correct?
That is correct, absolutely. And this is so therefore the technique of the the technique of what we do with the metal DES are different than what we are going to do with the BVS. Yes, but key that if you do it right, on long term it may be much better. Why? Because the ostium is the struts or scaffold will disappear. So you really will have, while there always will be a little metal stent struts on the side branch ostium, with the BVS that will disappear. So the long run may even be better.
And the key is even the carina may be better, no, long term?
Yeah.
Okay.
Absolutely. So therefore, now you see that there are a lot of studies which have been published on the bioresorbable scaffold, but majority of them have excluded the bifurcation lesion, or they have included very small percentage of bifurcation. The largest, I would say, was from the ghost use registry, where there like 44% bifurcation lesions were used, included, because they were all comer. So basically, the main data of the BVS or 1 year outcome was from this the registry, where clinical outcome following bioresorbable scaffold in bifurcation lesion, and key is the provisional versus double stent strategy. As overall seems to be that yes, you can use 2 stent strategy also, but we always use the provisional, but 1-2 stent strategy may have a slightly higher scaffold or stent thrombosis, but overall reasonable outcome. So clearly that if you do correctly, the overall event rate will be lower or identical. I would say that not lower, identical to a metal DES, except the scaffold thrombosis. Now, there are many other data also which have been published on this field, that the large series of patients where you do a pre and post PCI, that with the using the absorb in the main vessel, that you see the side branch really does not get compromised. Although we worry about the strut thickness and side branch compromise, it is not that common. So, usually, and actually if you see the absorb 2 study, they have found a slightly lower side branch compromise in the absorb compared to Zions, which is a little unusual, although in absorb 3 we found little more side branch compromise clearly with the large strut. So, that concern always there, but yes, overall studies have shown okay, and slightly higher, I would say, as I mentioned, the scaffold or stent thrombosis of 2.5 or 3%, which usually we know is about 1 to 1.5, and of course, overall reasonable MACE and the mortality in this large series of patients. Now, then this basically puts it together that yes, it is possible, and the side branch impairment is not common, but could happen. So, we need to be careful about. The real data comes from the GHOST registry, which really told us about higher the first signal of a systematic analysis of higher scaffold thrombosis, and in this study of for the 1200 patients, the about 44% cases they have the provisional single stent, or they have a systemic double stent. So, 260 versus 42, and basically was decided based on the side branch involvement, the long side branch lesion, diffuse disease, large vessel, they went for the 2-stent strategy, and they have very nice the flow diagram that when we use a 2-stent strategy, which is not common, but in some cases it still will be required because of the diffuse disease like this kind of case, angulated lesion and so. And of course, when you have ACS or diabetes, they have a higher event rate with the stent strategy in the main vessel. Now, as you see, many of these cases of the bifurcation in the routine practice, it is the BVS in the main vessel and the side branch is the DES, and this is a very, very important point, which is going to carry message throughout, that your main vessel, the stent, many cases you may require 2 stent, but the main vessel will be the BVS and side branch will be the metal DES. Yeah, okay. Now, therefore, so basically the conclusion was that in these cases BVS used for coronary bifurcation lesion in all comer population was associated with acceptable target lesion failure rates up to a median follow up of up to basically the 1 year midterm follow up. However, stent thrombosis rates were higher and seen with clearly the in more compared to our the metal DES. So, clearly this is where we need to be careful. In this study, they do not have a routine post dilatation, IVUS and OCT was not routinely used. So, clearly these technique will improve overall our outcome. So, another data on the bioabsorbable scaffold in the complex coronary lesion, you continue this, that can be excellent angiographic results with a 2-stent technique, but if you used to that use a T-stenting with if you are using a BVS, largely because you cannot overlap the metal or crush it into the main vessel using the BVS. It is very, very important point. So, then the very nice article by Colombo in the last month issue of the JACC intervention is goes through the various techniques and issues of the bifurcation lesion using the bioresorbable scaffold, and same thing the emphasizing that majority of the time when the tube bifurcation, and if it is not a large side branch or side branch is not easy, difficult to wire or not a diffuse disease, you should go with a provisional stent strategy. But I would say about 25-30% of cases will be that you will have a side branch as disease, and you know that you are going to put a 2-second stent. So, better you prepare yourself with a 2-stent strategy, but see here the majority of them, their recommendation still is elective 2 BRS or metal DES in the side branch. So, key still remain that is small that recommendation by the author, and I will come back to that subsequently, that is that try to do if possible the metal DES in the side branch and just the 2 BRS in a rare situation, in my opinion, in the bifurcation lesion. And this basically little extension for the provisional stent strategy, that if you know that we have done the good lesion preparation, stent deployment, proximal dilatation, and then also very important that when you do a kissing balloon inflation, you do a mini kissing balloon inflation. Just 1 minute. Mini kissing, not with a high pressure, just a low pressure, 8 to 10 atmosphere, compliant to non-compliant balloon through the stent strut for the scaffold struts. So, do not go to high pressure, so that you do not cause the disruption of the scaffold, very important. Now, if you cannot have the provisional, as we understand that particularly if you have more than angle of 90 degree, then you can put a BRS or BVS in the side branch, not a problem. But key is that just to have a very little kissing balloon dilatation pre or post, very important, and of course, if you have more angulated, then you have to use a tap. So, tap or T in the provisional. Now, more important is if you decide elective 2 scaffold, you want to say okay, I am going to use the 2 stent strategy, and side branch has to be more than 2.75, that is our goal. And so, what you do, if your lesion is more than 90 degree angle side branch, vessel is 2.75, you can do a 2 stent strategy. You can use 2 BRS, not a problem. Mandate the first kissing balloon after the side branch stent, and then no final kissing balloon if possible, or do a very small balloon dilatation for the side branch. Very, very important kissing balloon inflation. Now, if the angulation is not favorable, then you do a mini crush or modified T or hybrid crush, basically with the DES in the side branch. Always the message is that once you have put a stent in the main vessel, or you have a BRS or BVS in the main vessel, that you should avoid the final kissing balloon inflation, or do just a mini KBI. That is the term coming up now. Do a mini KBI, not with a high pressure, and so. So, very, very important. And the latest data have come that you better technique would be that you proximal optimize in bifurcation lesion, you put a stent across, do a pot proximally, then you go through it, open the side branch, and then after the side branch opening, now you have to do a pot again. So, re-pot. So, basically they are saying the re-pot, avoid the kissing balloon dilatation, go through the strut side branch, open the side branch, and do the re-pot, and that really gives you the best apposition and the good stent expansion both for the left main as well as for the non-left main. So, clearly that this fractal coronary bifurcation bench test really tells us that the proximal bifurcation, the pot technique is very good. Now Dr. Keeney is ready now here for the rota of the LAD with the 1.5, so that we can come back here, and the wire we are going to advance a little bit more. Go. Wire is not going further, but that is okay, right? Good. So, it is a 1.5. We have done the regular techniques of removing the tension from the burr. The 1.75. 1.75. Yeah, but let us see. So, this is the key. Yeah. So, we have a 1.75 burr. So, we are trying to see how it goes, easy or not. We can always downgrade it to 1.5. The guide is too much. No? Definitely looks a bigger bar.
Yeah. So, Samin, if for whatever reason somebody did not want to or could not do rotablation, how would you suggest this lesion?
No, this one I think you can use a high pressure balloon dilatation if required, which is completely fine also, because this is not a tram track both wall calcium.
Take it out.
Hold it. Now, good. Go to cine. Go to quick cine. Cine. Yeah, I think you could go with this, because this is my test. If your burr is in the proximal vessel, you give a dye. If there is total occlusion, that means burr is too big.
Already
wonderful.
Huh? Okay. You want to come out? Okay. We get a 1.5
That's a very, very nice, very elegant way. I've never seen it, somebody describe it so perfectly. Yeah. That would be a nice way for you to have checked if it is too big.
Yes.
Okay. Strange, we've been showing rotablator cases here, several dozens. This matter never came up.
Yes.
So you're downsizing to 1.5?
1.5, yeah.
Okay. Anu, how much was the speed there?
About 155.
Okay.
This is 1.75.
So the two terms from what you presented, which the viewers should become familiar with, is report and mini KBI here.
Yes, exactly.
Okay.
So for this bifurcation, lesion definitely once we are using with the BVS, very important points.
Now you do have a plan of using imaging before deploying the BVS, no?
Yes, so that is actually we are ready with the OCT, and we now our experience has been like 25, maybe about actually 30 clinical cases of BVS, and we are used in all situations, the overlap, bifurcation, and so forth, but trying to keep it into the vessel, the 3 millimeter and above. We
So-
actually we haven't used any 2.5 millimeter yet.
So in all the cases you used OCT?
All cases except one.
Okay.
One case with the stent, one case of the stent ISR, that case we did without OCT, but rest of the cases all have been using the.
So what was the real lesson which you learned here? It was helping you with sizing most of all?
Yeah, and sizing, and but actually, more important what we are learning is that you do see some the dissections, which are basically, you want to go?
I don't know, let's see.
Huh? Yeah, that the silent dissections which because of the lengthwise, what is the length? 1.7 millimeter?
1.7, no. More important, I think, is your optimization. As long as sizing it does not help so much, we thought it will help. Believe me, it's giving us smaller size than what you would have angiographically picked. But more important is that post dilation, that your stent optimization is good. OCT really helps.
So Samin, here is the real tricky situation. So if somebody does not have OCT, should they not use BVS today?
No, I would say
IVUS.
that, or IVUS,
Okay.
and I'm sure majority of the labs have IVUS. And what we learned, and that is the question is, you don't have IVUS, you don't have OCT. What is the impact? Should you not use the absorb? I would say you could, but you have to be very aggressive, because reason is, the reason basically is that we learned that once you don't use these techniques, that those are the one associated with higher scaffold thrombosis, like they have in the GHOST, where GHOST EU registry, where there was a post dilatation was in 44% of cases and imaging was in 20%. So clearly, so those factors are very important for understanding basically, that for the understanding of the deployment technique. So the key is, now let's say your question that based on the OCT, how many times we post dilated? I can tell you, because of OCT, post BVS, we are not post dilated single case.
Right.
What we did, we just learned some cases we have a long dissection, which was 1.7. What was the criteria in the?
No, the criteria is based on the DES, trials, which have shown that if you have a dissection flap of greater than 1.7 millimeter, you definitely, they also based on the angle of the dissection flap, but when you have more than 1.7, you definitely have to place another stent. But other dissection that you see, both proximal edge and distal edge, usually you don't take care of it, they heal better when they come back.
Anu, several of these dissections you could not angiographically.
No, you'll not see it angiographically. I think that's other
right.
thing also important point, that if you're not seeing it angiographically,
That does
then,
not mean that.
you got to do 2 views, and in the 2 views, if you don't see it, then go ahead, leave it.
All excellent points, fine realignments which we have to do in our techniques for BVS, but very important points. So this is the 1.5 burr.
This
1.5 bar, yeah.
Even that is giving very difficulty.
You have the run through and the fielder wire.
So last month we had Dr. Chuck Simonton join us, and the salient message which he seemed to be giving us is you need to prepare the lesion, image it, and then post-expand, PIP.
22, 23, 24, 25 seconds.
think
I don't know how much
you went
patience
far
everybody
enough.
will have to do this much of work.
Yeah, well, it's. I think lesion preparation is going to facilitate deployment of the stent considerably.
Good.
Yes.
Connect. Connect. Good. Come on.
Samin, could this case have been done with the 6 French?
Well, I mean,
Now, since we are planning to stent the
Dedicated,
diag,
yeah.
I think
Okay.
you've got to go 7 French.
Perfect.
and I think this kind of case, if there is no contraindication, high creatinine, or
Oh,
yeah,
yeah.
the-
Okay, the question is very good since the technique is completely changing. Remember, we always showed bifurcation modified T where you're going to go up with 2 stents same time. 7 French is essential. Now with the BVS, since we are going to do, bare metal, metal DS in the side branch, and then we're going to do the BVS in the main vessel. Are we going to place both same time?
yeah, that's
No.
the plan.
We said balloon, piece,
Yes.
dilate.
Yeah. No, but simultaneous, yeah.
Samin, in the ghost trial with the slightly higher stent thrombosis rate and some of the lessons learned, did they modify the dual antiplatelet therapy in any way?
Well, I mean, they actually, as such, the antiplatelet therapy was the contemporary.
Right,
and
for
it
12
was
months.
used like almost 20%. These were not acute coronary cases. So therefore, it was run of the mill. So in about 20% of cases, you
Some
use
dye?
more strong.
Okay, good. Very
All
good.
right, now we have the wire nicely anchored.
Yep. Let's take a picture. So then, because then you are going to do the
Predilate the diagonal.
Ooh.
both.
Dissection of that area.
Good. Let's do the balloon first. You want to put a wire into the diagonal first? You prepare the.
We're going to wire the diag. We went with the run through to the main LAD.
Right. Samin, you mentioned you've done 30 cases post-approval,
Yes.
and those 30 cases, most of them were the kind of complex cases we show.
Well, both. Actually, there some of them are simple, easy, but of the 30, 10 are with the atherectomy, and about another like 6 are overlapping. And we bifurcation situations like this, and none of the cases we have done that we have used 2 BVS.
Were you surprised with any of the cases as to the difficulty of placing
No,
the
so
BVS?
far actually it's working out. I think compared to what we have the investigational absorb, BVS,
Experience.
this GT1 system is a better delivery the balloon, and it really is working out much better than we have investigational absorb.
Well, I had in the last month's case, I had observed and almost predicted that you will always do very well with BVS, because I have not known any site or anybody to be doing more lesion preparation even for routine cases.
Yes.
And I think particularly I think the use of rotational ablation for the calcified cases will make it so much easier.
Yeah. So, but one thing for sure we are noticing that in a very tight lesion, even if you do rotablation, at the tightest you really cannot bring down to 0%.
Right.
You always have, although on the OCT it looks nicely expanded, but you see a little
you
bit.
see well opposed.
Well
but
opposed, yeah.
You on angiographically you always have a 10-20% lesion. Means though the struts are thicker, for some reason, no matter how high you go with the post dilation,
20
there's a
millimeters.
Have you
10 to 20%
done a
residual.
few more distal lesions? Any problem deploying there?
I'm going.
No.
Okay. Samin, there are 2 questions which have come for you. One is that have there been any
Down.
supply or sizing issues with BVS?
Well, actually, expiry is very common. That you have a little bit of a cover, their temperature off, so that it say good or bad. So
Drop.
And that's a big issue. So
No,
yeah,
but also the length, we only have a 28 millimeter length. We are used to 38.
go a little center.
Right.
Yeah. So that definitely is the big issue. Good.
Up here.
So the next
Yeah.
improvements which one can foresee with BVS are going to be different lengths
back?
and
This is a
smaller,
2.5.
thinner struts, no?
2.5.
Do you want to post in that middle area?
Huh? So this is
Did
okay
not
right now.
expand well.
Yeah. Now right now expanded good. You want to see it?
Go up again.
Okay. Now the key is that you need to have a full expansion
See that?
before you put a stent. So question is that I think it's a okay, or you want to do a either angiosculpt here at high pressure. Okay, let's bring back in the guide. Take a picture.
No,
Then we'll
okay,
see.
what do you want for the
2.5. Let's get a 2.520 for the side branch, high pressure balloon.
go?
Looking good.
Yes.
So are you planning any angiosculpt there or proceed
looking
with?
good.
Yeah, looking good.
No, it's a fully expanded.
So you'll pre-dilate the diagonal at this stage?
Yes. Or you want to do the OCT first?
No. Let's take care of the diag. No? Or you want to do the OCT?
No, but
I don't know why you need OCT. You want to? Okay, let's do the OCT.
okay, keep it there. All right. So we are going to do the OCT now.
It's very small vessel.
So Anu, angiographically, what would be your prediction of the size here?
Oh, angiographically, we will put the question now.
3O?
I don't know, they come 275? No.
No.
Too big, too big.
3
You want to put a 3?
Okay, so let's see what OCT shows us.
OCT will show you 2.2.
Go.
Uh, 3O proximal. It's too big. This is too big. They come 275 or no?
No.
Samin, have you done any CTOs with the BVS?
Yeah, no. We have not done any CTO. We have done, as I said, the bifurcation.
No,
patient
no
with a
left
non-STEMI,
mains?
Huh?
and no left mains.
Okay.
I told you it has to come, the package has to come with extra patience. Samir, you heard me?
Yes, 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 absolutely.
So,
No, look, that is, I think, beyond techniques, it is the patience which you need with any new technology. Master it first, but these are invaluable lessons, and I'm glad that we took the lead, and we are having focused BVS cases for the next several sessions.
can we put this on? No?
Put the OCT on the screen.
Wrong button you're pressing. Yeah? And they're still not able to fix this.
Good. They have it. Good. Okay.
Oh, you're going to press it? Why nobody connected that? Give me. It's connected? Give
No,
me.
we get a big syringe.
No, stop that. No, where is the connection? Okay, here. What is all this now? Only this one? Oh.
What is it? Okay, so we are ready for the OCT. Good clearance.
There's no dye? Ah, what? Good, right? Closer. Okay, ready? of delay.
Good. Okay. Teach us what we see there. Meanwhile, we'll dilate the
You'll
diagram.
just see calcium and dissection. Give at the level of the diag, right? Just give
Yeah.
us a cross-sectional area there. Vessel size. So you go doing the co-registration? Good.
But lumen has nicely opened up.
Yes.
And what is the vessel size based on the OCT?
Yeah, right there, right there.
That is exactly
No,
what I
come
was.
back, come back. Yeah, give us there, that's good, right there. Get us a diameter.
So, I mean, based on what you have observed with the OCT, no reason for more lesion preparation?
You mean today's case?
No, right there in the mid portion of it, do you think it requires, as you were thinking of an angiosculpt before?
Diameter. Mean
Vessel
diameter
is
of 1.98. I said 2.2. So
Okay.
less than
Maximum is
that.
2.6.
Yeah, so, but then you want to put a 3.0.
Right. So this is where how is the less experienced operator supposed to be making decision based on this now?
No, angiographically, I think you would use a 275 stent there. I mean, distally you will put a 2.5 stent, proximally you will put a 275 stent, and you just do the same thing. But they don't come with 275, so then you have to make a decision, 2.5 or 3.0.
Yeah, 2.5 maybe distally and proximally 3.0.
No,
So
two-
we need a
yeah,
two
2.5.
stents there. Yeah, good. That's talent here.
Distally what?
The 2.5?
Yeah, distally 2.5.
Yep.
Now at the ostium, do you want to do cutting balloon?
Okay, let's see it now. This has opened up nicely. It's a 14 atmosphere, 2.5. You want to do let's take a picture. And if need to be high, we are low threshold of doing lesion preparation. Same way. That okay.
Okay, ready?
Ready? Yeah.
Go.
If you want, we can use it now.
What? Cutting
2.
balloon?
Yeah, if want, but it looks okay.
Probably don't need any cutting balloon.
There's just a chunk of calcium at that
Okay,
ostium.
then fine. Then
2.5.
let's get the 2.56 flextome.
So what would be the BVS size you are planning here now? 3 and 2.5?
Yeah, because we don't have a 275. If you ask me what is the metal DS that we are going to be using here, would be a 275, 38 long.
Right through.
Now since we don't have that, we will go with the 3028 BVS proximally,
And at
then we will
2.5.
do a 2.5 distally.
What length? Again 28? Probably shorter,
know,
no?
maybe
Shorter,
shorter.
yeah.
28 and maybe an 18.
And
2.5,
you
18.
and you're planning to use the cutting balloon for the ostia there.
Ostium of the side, and the diag, what size you want?
I think 2.5, 24 Promus.
Good, get it. I would have gone 2.5.
No, 2.5.
Okay, 2.5, 24 Promus for the side.
Sameer, another question for you has come. Have you had any STEMI for which a BVS has been used?
Not
No.
yet, no.
Okay.
But I think that's where with the better endothelialization
Right.
with the trophy studies, so it
Oh,
definitely will be a better approach.
Particularly with a lot of these lesions
Yeah.
being larger and in
Exactly.
proximal segments.
Yes. And the data have shown by Everbio and other trials that it's completely safe. And as long
why
as you
is she
follow the
moving
same.
so much? See that? That is
Crisscross?
a chunk- No crisscross, just a chunk of calcium there.
I see. So still there is a calcium at the before the bifurcation lesion, preventing this
Passage.
flextome to go.
Right.
we can start cutting from here.
Okay.
Huh?
Okay. Try.
Okay. So we are going. So same. As long as
Okay, went in. Wait.
Okay.
Okay. Good.
good.
Oh. Okay. Now. Okay. For basic. Okay. Go up now.
Yeah, open nicely at 8 atmosphere. Okay.
You still see that chunk?
Yeah.
Down.
But open nicely. Yeah.
Okay. Get us a 24 Promus now.
That was a 2.5, no?
Yeah.
Yes.
Go up again. Sir.
Yep. Good. We have to tell her to put her hands to the side.
After her previous stent to the circumflex, to the Ramus, what dual antiplatelets?
Plavix aspirin.
Okay.
Now question is, should we change now to a ticagrelor or pressagrelor after today? That's the only issue. No, but let me put first. You put a BVS distal to the before we put this bifurcation.
I think do it later.
Why would you want to change the dual antiplatelet to the instead
Because
of
the more complex the double
The
layer
lesion,
of
okay.
the bifurcation lesion, that will be the one. No, but why don't we put one stent in the distal?
You don't know how much overlap you'll have. Do it later on, so you can change the length, you know.
Okay. Fine. Keep the 2.5 balloon. We are going to
It's
crush
moving
it.
too much.
Talk to the patient. Give some medicine. What need to be done? Because will be less problem in going further. Okay. Anyway, go.
So
We'll put a
this-
balloon in the main vessel. Yeah. We'll
this
do a
is the
little
stent
crush.
for the diagonal now?
Yes.
No, you want it simultaneous. Right now, earlier you said you want simultaneous.
No, simultaneous. But first you have to crush. Oh, the
You're
ostium.
talking. No.
Yeah. The question comes is, let's take a last picture. We are not taking a picture now.
No, it's okay. Don't take a
Yeah.
picture. Go back to that
Okay.
one.
Good. Sure. That what should be the strategy now? I think that's the key. So one is that we put a stent BVS in the distal vessel. Usually we try to do if there is an issue about overlap. So here I would say safely we can put a 2.5 28 after the bifurcation lesion.
Coming right up to the bifurcation.
Yeah.
Okay.
Remember there is up to the septal, there is a dissection. You can take a 2.5 28 without any problem. And then we do our kissing with the 2 stent technique with the
28 will cover the bifurcation. Your 28 will come from the first septal up to the third septal.
okay. So good. So we can take 18. We can take
That's
2.5
that-
18. Huh?
Then 28 may be too
And
much, and you may
no,
come
will
up
not be
to
too
the-
much. No, will not be too much. Okay. So let's get a 2.5
Otherwise,
18
we will
BVS.
have too much overlap of the BVS.
Yeah, will not be. 2.5 18. Yeah. Do you want to take this one out?
My thing is, let's do. You want a 3 or 28, right?
Okay.
Proximally.
Now,
Makes
other
sense.
one we also can do. You deploy the stent, do a mini crush, open the ostium. We are not doing a simultaneous, which is okay.
Too many steps.
Yeah, which is okay. Too many steps with the 2 technique.
Okay, that is a 2.5 balloon.
Yes.
Some dye here. I think the wire is in some other branch.
Yeah, 24 is quite long.
Exactly, I'm saying the length of the BVS will be. There will be a lot of overlap.
Yeah, but we can do 18. If required, 18 18 will be
Yeah.
okay.
Okay.
Good. Okay. Yeah. This is for the main vessel.
You want to change the length?
Which one? No,
Calm
this is
down.
okay. Huh?
It's not too far distally. Vessel.
Okay, you want to change to 20. The side branch, the question is that 24 is too long, although see if the wire is in the main vessel, see that? Yes. So what we are going to do is the mini crush and the kissing balloon inflation beforehand. Good. Okay, ready? Good. Okay.
Take a scene.
Okay.
Okay, go up with the side branch stand now. This one. Yeah.
We'll go 12.
Good. Okay. Down. Go up again.
That was 12 atmospheres.
Yes.
Okay.
So now we are deployed because remember the diagonal is like barely just at the 2.5
Yeah.
vessel size.
So now we take out everything.
No need to go much higher.
Yeah.
What is it's a Promus stent there?
Yeah.
Yes.
Okay.
Take out the wire also.
Yep, that's fine. Good.
Crush it.
Okay, go. 10, 12, 14.
So absolutely no problem getting the stent there,
15.
the BVS.
Yeah. Hopefully will not be because right now we are dilated this crushed a little bit negative.
Right.
And that is our technique now.
It's a 20 SS. Look.
How high did you go there?
This is
Which one? This was
16 atmosphere for the 2.5 balloon. We can take this out. You still have that wire. So if you see if you can put a wire into the side branch, give us a 2.5, 12 or 15 compliant balloon. Put this into the guide. Pull back.
how high you went. You crushed it well.
Yeah, it is done. Good. You want to take a picture now?
Now let's
Sure.
recross it.
Yep.
Then we take a picture. Okay.
Okay. Cine. Okay. Do it again.
You want to do hand?
Good.
Well, the diagonal looks pristine.
Fine. Yes. So far so good. Good. But now we have to do a kissing balloon dilatation.
Of what?
Yeah, which is fine. Ostium. We have to open the ostium.
Oh.
Remember, you do a the key is the kissing balloon inflation should be done before the BVS with the plan that in the end you may not need any kissing balloon inflation, or if you have to do it, you have to do a mini KBI. So
Right.
now we are going to open the ostium of the diagonal. The reason is that we don't want this to be that avoid if there is a good blood flow that you avoid. And reason is why that is compared to what we have been teaching that you.
So we go with the 2.5.
Yeah, that this is open nicely.
So to avoid
No, but
the-
you want to put a balloon kissing. You have to put this one too. Yeah.
No, why kiss?
No, but because strut will be impinged now. Remember, we have opened the strut which will impinge. This one, low pressure. Go, kissing. So basically, the key. Yeah, good. Yeah. So remember what happened is
2.5.
you had to do a kissing.
yeah,
BVS,
so that
2.5,
the
Go up.
right.
Because key is that when you open the ostial strut of the diagonal, some of them will be crushed and will come into the lumen. So you have to do a kissing balloon inflation now. Good, negative.
This is just 6 to 8 atmospheres.
That's it. The main vessel you can do more, and the side branch we opened as a 12 atmosphere. So we are prepared now. Idea is that we try not to do a final kissing balloon inflation. So that is the whole technique issue. And because of you don't want the disruption, possible disruption. Okay, this wire is out.
How many people watching?
okay, get us the 2.5, right? We want to open the 2.528 and then proximally we put a 3.0.
No, 1 second. 2.5 which will overlap, or you want to put after the diagonal? See the picture?
What I want to do is first you have to put distal, no?
Yeah.
So that's the
We can do
2518 you
proximal
have?
also. If you want, we can put a proximal. And just take one picture now and decide. Okay.
So
Samir,
you're
would-
starting at the third septal,
Yes.
coming up to the
Yeah.
first septal. That
Would it
28 will
have
cover it.
helped to give some intracoronary nitro at this stage? To
Your pressure was on low side, but
Okay.
yes, definitely will give, and the flush it. Yeah. So now we are good. So question is, we can do two ways. I can tell you that I think, but we should put one distal first. We are giving
25
nitrogen
28
now. Or
18.
18 is fine. Okay. Tell us
Yeah.
what you're going in your mind. Yeah.
I'm saying you have to, so you will decrease the overlap, okay? You
Right.
should not overlap, right, with the
Yeah.
BVS?
Yes.
So then if you are going to go 2.528, you'll come up to the first septal,
Yeah.
right?
Yeah. Yeah.
And then you can take, we don't have 15, right?
No.
BVS doesn't come.
Then you could use the 3018.
That will be still too long.
Too long.
Then you have to do 3028 from the ostial LAD to wherever it goes. Then you put a distally.
Yeah. So I can tell you what we could do here. We can put a 3028 now, and then through it we go to put a distal one.
Yeah.
Depending on how much.
Yeah, whether it is 12
Good.
or 18.
Okay, let's get a
That's what I have been
3028.
telling from the
So with
beginning.
that has been, so we can finish my
Goal is
second
to decrease the overlap.
minimal overlap. Yes. So with that, if we can come to the slide very quickly, so I can talk about one more point which we had.
3 or 28, okay.
If we can go to the slides, that impact of the FFR value post PCI. We all know the pre-PCI FFR is very important, and the 0.8 and below has been the cutoff. More than 0.8 medical therapy, 8 and below, 0.8 and below has been associated with higher event rate on medical therapy. So all the standard has become gold standard that you do a PCI on those cases. Now clearly what also we have learned that even
How many
after
on YouTube?
PCI, many cases will have a FFR of less than 0.8, and that is the key. And those tertile which will have a post PCI we are talking now, after PCI, that you have a lower that your FFR in about 20% of cases will be less than 0.8, and those are associated with a bad outcome or higher MACE at follow-up. So very, very important point which has come up. So this actually has been the relation of fractional flow reserve after DES and 1 year outcome. Clearly you have less than 0.8 or 0.9, 86 or 0.9 associated with higher event rate. Ideally you want to get it to 0.9. This study associated with higher the event rate if it was more than less than 0.9, and the residual plaque volume is probably the region that where a MACE or no MACE, your FFR is clearly lower in patients who have associated MACE, and this is one of the important predictor. So what actually has been a more systematic analysis has been with the post-intervention fractional flow reserve to optimize acute results of the PCI, and they showed that even angiographically looking good, 21% will have a low FFR of less than 0.8, and you post dilate, sometimes high pressure, you put additional stenting or combination with the imaging, you then bring it down to 9% the FFR of less than 0.8. So very important. Key is that post procedure subsequent intervention will improve your FFR, but some cases will remain still low FFR less than 0.8, and this is basically showing and what is it has shown that by doing an intervention you improve your FFR post PCI, and clearly the DES or BMS cutoff was 0.86 in terms of the survival and the TVR. So 8.6, more than 8.6 was good, less than 8.6 was bad, and clearly that I would say some data have 0.9. So key is that this is where we should be and associated with high bad outcome in patients with where we have a FFR of less than 0.8. Now of the various characteristics, FFR of less than 0.86 was associated with the higher MACE rate, as you can see here, and one of the important predictor of bad outcome. So clearly what happened is that FFR post PCI has added to the value of our baseline clinical angiographic characteristics and FFR really prognostic value, incremental value of the PCI. So FFR post PCI has come up to show that if it is lower than 0.86 or 0.9, we'll have a bad event, so we should optimize. So question is why not? Because various factors are unmasked second lesion and diffuse disease, in my opinion. Clearly what you need to do is high pressure dilatation, imaging, and in some cases there are the dissection, optimization of the stent is very important. This is what we learned for the BVS. So now Anu is ready here to do, you want to just, you're out of the ostium, good, okay. So slow inflation, this is, tell us what size, what you have.
3028.
It's a 3028, 6, 8,
See now the distal is too big, I guess.
10, 10 and
Enough,
12.
enough,
So
enough.
clearly that deploy the BVS at 12 atmosphere. Don't go higher. Why? Because you are going to post dilate 100% anyway. So 12 atmosphere go overall for 30 seconds.
Samin, explain to us about the stent location and the markers.
Yeah.
This
So
is
here you don't see the stent location, you will only see the marker.
No, that's
If
what
you
I'm
saw-
saying.
Yeah.
The- in
right now, no,
reference-
once you take out the balloon, then you can see the marker.
Yeah. So marker is about 0.3 millimeter inside edges.
Now you start seeing the marker.
Yeah,
You
you're-
want to go up again? Or is done?
No, no, this is done.
Distal edge,
This is
didn't
done.
op- distal part didn't
Yeah, you
open up
want
well.
to go further? Yeah. No, that's okay. We will have other balloon.
Okay, I'm coming out.
Yeah.
Okay, ready?
Yeah. No, do a cine first before we inject, so we can show that marker. Yeah, good.
Okay, go up
Yeah.
now. See?
Yeah. Good. So
looks
far good.
Okay,
wonderful
let
there.
us, actually, 12
18?
may cover it as
18,
18 is too long.
18, that's okay. Healthy overlap in the healthy vessel is not a problem. 2.5, 18. So now basically,
Cannot go.
yeah. So the question always comes that do you need to dilate? Yeah, give it. The key is that here, when you are inflating, you will not see it. Let's come out. That once you have deflated and the stent is about 0.3 millimeter outside. So that's the key.
outside the
The
marker.
3 millimeter marker, yeah. It's between 1 to 3 millimeter based on the stent size, and so you have any time when you are dilating at the marker, you're fully covered. So your post dilatation balloon could be 1 millimeter outside those nickel dots, a platinum marker, right? Those platinum markers. So you see it here. If you can do a cine again once.
Now you see it, the
Yeah.
marker.
Yeah, the proximal marker and distal marker.
So a stent boost can also be pretty useful in.
Yes, that is true.
Yeah, the markers can be seen pretty well.
Yeah.
Anu, why had you removed the wire? It just came out, or
It came out.
okay?
Need a new run through.
No, I think the guy.
Yeah. Yeah, it's a VL30. Despite it has dives in. Huh? Get a new.
No.
Straight out here.
Yeah, don't. Okay.
Wiring through the BVS one or with
Well,
the
no,
PCI.
but not
more than that, I was worried
There
about
was a
the
little
flap
dissection there.
flap of the dissection.
Hands by your side.
Don't we show the die? Pull back here in the dissection plate. You have to pull back a little more.
Now we are good.
Yeah, not good. The wire has been beaten up.
Yeah, not worth it to disrupt that dissection there.
Why don't you get to the new wire? We got you run through or no?
I can tell you it's sticking out so much.
What is sticking out now?
The wire. Means going through the, okay, some die. Oh.
Yeah, let's go to the new wire. Just take this out. Don't cut short. Yeah, because the wire tip is so badly done.
No, I think the wiring through a BVS is not that easy.
Okay, here. We need a balloon support there. Get at the 2.5 balloon.
2O.
Huh?
2O12.
Okay, 2O12. Good. Get the balloon. Go to some different view. Got it?
Yeah.
You want to get a balloon now?
I think it's totally changed the orientation of the vessel. Some die.
Good. Go to epicranial now.
This
Good.
is in the
Hold.
LED.
Don't go anywhere till we go.
Now die.
Looks all right.
You need a give us a whisper wire also.
Yeah, I think a whisper is a very good choice here. So the other lesson to have learned today is post-PCI FFR 0.86 or more.
Yes. So I think some data up to 0.9. So I think we should target 0.9.
Anywhere between, okay.
Yeah. Okay, then we use a long balloon 220 now, compliant.
I would put a dermatolent.
Yeah,
I mean,
which is fine, DES now. Now also the 3 cases of this 25 plus cases we are done, we found some edge dissection either proximal or distal with the BVS. In all those 3 cases I did not put a second BVS. I just went with the metal DES.
Okay.
So this case now what we have now because of the dissection, the question is where it's a long segment, should we go with the that's what I was just talking to Dr. Keeney, that maybe we should put a DES now and not the BVS distal.
And the reason for that is because it will be difficult to deploy it?
No, I think one is that the overlap, because you don't want to have a not overlap segment, and
Right.
these are the edge dissection, so that definitely will going to do a you want to overlap those segments. The will die.
the vessel is close now.
Yeah.
Just in the dissection.
And this is the whisper wire.
Yeah.
Fielder, maybe not.
Okay. You want to try fielder?
Not very good.
Should be okay. Yeah.
Yeah. Very good.
Yeah, for a moment I thought it has entered a false lumen into the
Some
proximal, but we should be okay, I think.
Some die.
Yeah.
Good.
So,
You can post dilate now. Okay.
That is a 2 or 30 balloon.
A
Right?
2.2530 balloon. 2.2530. We don't have 2 or 30. 2.2530. Good.
And-
so
and
now question is that I think the dissection occurred. We do always have a little bit of dissection post, but it just occurred by the wire. It's not this one. I would not call it a dissection from the BVS. What do you say?
I think it was clearly the wire. I mean,
Yeah.
because the picture which was taken after the first BVS looks all right, but
And I can tell you in the dissection channel, the whisper is the way to
wonderful
go.
wire to go.
Wonderful
yeah.
wire.
Yeah. It's,
Go.
We are doing techniques that are not usually that we do, which
Right,
is normally
right.
you do a distal stent and then you do a proximal stent.
Proximal,
To
yeah.
avoid overlap, we did this way. So, you know, there are a lot of things that are changing. We just have to be careful.
I think this is precisely where these cases would be so instructional. I think just fine tuning of some of the techniques which we've been using
Here.
with the standard techniques. So this is a 2.5 long balloon,
We can take the run
2
through wire.
balloon, no, 2 to 5.
2 to
Yeah,
5.
yeah, yeah.
So, but we need to go a little further. And the stent actually now could be a 2.5 or 2.25,
38?
30, 33 or 38. Yeah. Go a little further.
32,
32, 33.
32 now.
You'll see. A little bit more. No, you want to go a little distal.
No, we don't
Yeah,
have
good,
that
good.
long.
Here. No, this is the one. Low pressure.
Good down. What you want? 2.5?
I think take a picture. I think we can take a 2.532. I'm 32 or this is 30.
Yeah, 32.
Okay.
Question is
Let's
2
take-
to
where is the
5,
dissection?
2 to 5 or 2 to 5. Now we are good with everything.
Yeah.
We just 32.
Good. Bring back in the guide. And let's take a picture. Ready?
Ready.
I think you could put a 2.5, no?
Yeah. I think 2.5.
You need that long? 32?
Yeah, 32. Because there
No,
was a
see your
dissection.
dot is there.
Yeah.
You don't need that long. 28?
28, 24.
No. 28 for definite. The question is where did the dissection?
Go minus. Dissection
We don't have.
in relation to
Right,
the
10
septum.
millimeters
No, we have
after the.
minus. Keep going minus. You're
No,
going
no,
plus.
that way. No, that was only 12 millimeter.
Good. Yeah.
So you don't need that long, 32. Then you're 28 and we're done with it. See the way the dot is.
Yeah. No, I know. But putting a 32 is not wrong.
Too long. Okay.
Give
32.
us, give us 2.532.
Don't pull the-
You're using a Promus?
Yeah.
Yes.
Oh, you know what? We just want to make sure it will go through this BVS.
Yeah, it will go. It will go. Keep this balloon in case necessary. Now, you want to put run through now into the diagonal?
And the wire came back again.
Came back again? No,
Yeah.
no. This is always longer.
Yeah,
No, not longer. Remember? that?
182.
Yeah.
Okay, now
Yeah. Go.
in the diagonal?
Yes.
No, just come out. Do this stent and be done with it.
No, I think it's small, mini,
No need.
at least dilatation of the ostium should be done. Yeah, actually the question always has been that you have deployed the BVS, now you want to go distally. Do you need to post dilate before you go distally, which my personal experience has been that it goes through.
We
So
shall,
now we actually having a DES going through the BVS.
which should be
Yeah,
straightforward.
yeah, another test.
Too long. I'm telling you. So
Yeah, way too long.
Too
Good.
long. 28 we could have been okay. We'll have no space for the Lima.
Good. Ready?
Okay. Don't need too much
So
overlap.
ideally, how much overlap do you want here?
Probably none.
which is going to be very
Yeah,
difficult.
will be done because stent on the Promus is inside the stent material.
Yeah,
Ready?
yeah.
Go.
We will have
Go up.
maybe a millimeter overlap here now. Go up. This one you can go up quick.
6,
my
8, 10,
friend.
12.
Like
12
this
only.
time.
Good.
Down.
Go up again.
Okay, good. Down. Not get us a 3O high pressure balloon. Go up here.
Go up. You can go here 20.
No, not with this balloon.
Good.
Good.
Negative.
Enough.
Negative.
Down. Now let's try to wire
3O20?
side branch.
Yeah. Okay. So, or you want to do a pot proximal 3 of 15 actually. Give us a 3 of 15 only. Yeah.
No, the 20. You need to post where the overlap is. It's not expanded well. Yes. We'll try to wire the DAG with the
Yeah, try now.
other wire.
So that's the key. Oh, advance the whisper first. Whisper has come back again.
That's okay.
There may be no curve on that. Good. Very good. So if you want, we have the 2012, right? We still have 2012.
Now to take a cine now. We now don't have a cine.
Huh? Yeah. So we have 2012. Good. Go. Beautiful. I think 2012 side branch, low pressure inflation, and then we do so same. We are trying to avoid kissing, although we can put. I had done the kissing same. The low side branch pressure. You don't go to high pressure.
Look, both the vessels are looking perfect at this stage.
So we want to show that mini KBI.
Right.
And that is the key.
6 to 8 you mentioned?
Yep, that's it. An undersized balloon.
So the length of the distal stent ended up being okay.
Yeah,
Initially
very
we
good.
felt that it was too long, but that should be.
Good. Good. Leave it. Okay. Let's get the main vessel. Yeah. And we'll still do the final OCT run to make sure everything is in order. Good. So now, so first I am going to open the side branch. So this is our, we go to 8 atmosphere. It's undersized balloon, 2O.
Go to the high pressure of that one.
Yeah, now you can go to high pressure.
16, 18.
Yeah, cine both of the, see that? Both low
Down.
pressures. Yeah, negative.
I think the ostium of the diagonal, right? See that?
No, which is okay. We don't
No,
have to
not
worry
that.
about.
I'm not saying
I'm
that.
just saying that don't get too crazy about the ostial of the side branch because your strut will disappear. And so there will be a good blood flow. You're okay? What do you want now?
You have to go to the ostium, you have to go to the caudal before
Okay.
you go to the high pressure balloon.
So you need to bring the. Now where is the dot?
There you see that one?
Yep.
Which is the, you're the, you see the dot there?
Cine. So show it to everyone. Exactly
Okay,
at the
go up.
overlap. Yeah.
Go up.
Go up.
Yeah.
Yep.
Good.
16.
18. down. Okay, we take everything out except the wire of the LED
Yes.
for the OCT.
Now take a picture, one picture here.
Caudal picture.
Yeah.
Okay, ready? Go.
What is happening? Do it again. Try again.
Go. You can go.
Beautiful.
Looks absolutely wonderful.
Yes. Because this is more physician's time, hopefully there should be more reimbursement in putting the absorbed.
Yeah, look, I think
more important,
Anu's statement was exactly right.
Previous series here.
Yeah, that it requires much more patience, more time.
Tower is done faster now.
Okay, let's take a epicranial picture also.
Uh-oh. Again came out. Forget it, this one, right? Run through wire probably easier to go in.
We have that to run through. Get that run through wire.
Good.
Can you take a picture?
The only thing is at the overlap we did go,
Yeah, yeah.
right? Go.
Very good. I call it a VVG. Very, very good. What happened? That one was bad? Huh? Okay.
But you see the distal edge of the BVS and then the Promus, the overlap area. Still 10% residual. You see that, Isis?
Yeah, yeah.
Samir, do you see what we are talking?
Exactly how you had mentioned initially.
Yes.
That area never expanded,
Right.
and you will see it even on the OCT now.
But that's exactly what you don't want to overdo, because that would disrupt the struts, no?
Yes. Yeah. Basically, the data have been by Ormistan that you can increase by 0.8. Actually, it was not the pressure which made the difference; it was the size. So you can go up to 0.5. That's what the recommendation. Don't go 1. Because 0.8 is okay.
Get closer, guys. Pay attention. Two of you.
So that is why the whole issue of the 0.5 comes in. Good.
Okay. Open. Okay, can we see? Can you take that out? I cannot.
Yeah, we're still within the stand. That's okay. Go.
No, we are within the stand because we cannot get the entire
Yeah.
distal stand.
Yeah. Good. Good. Show us your overlap, and so I think that's more important now for you to analyze there.
That BVS that did not cross, give it back.
Put down both the BVS.
You did the thing? Coverage is done.
Yes.
So this is where.
Okay,
BVS
show
cross.
louder.
We are coming from, they're seeing it, right? We are coming from distal to proximal. You can see the co-registration, right? So this is the Promus stent. Coming back. We said we probably should get a 0.5 millimeter overlap. right there was an overlap, and now you see the BVS, the bricks,
Yep.
and some overlap with the. So this is where we expected, we did not see, where we thought the 10% residual was there, right here, angiographically.
Right.
So if you see at 11 o'clock position, not well opposed, but
So,
still within limits.
so would you do something different there, or
No,
you're
no.
okay?
Okay, now this is the side branch,
Right.
right here.
Mhm.
Strut has opened.
So what was your comment on the branch there, and how is the appearance of the overlap?
I think our kissing balloon has opened up. Can you see one of the brick going into the side
Yeah,
branch?
yeah.
Yeah. And you keep coming proximal, nice, nice. Everything is good. Okay. Up to the ostium. What is this side branch? Bilateral?
Yeah, that's high lateral. Good.
Yeah, came up to the ostium.
Looks very
That's good.
Beautiful. All
But
right.
I think we showed you at that point,
Yeah.
where the 10% residual,
Yeah.
it was not well opposed. But don't have to go back and post dilate.
Good. Go back to now. Question is, what apposition is allowed and what is not? Some people say the strut thickness. So if you have more than one scaffold or 1.5 scaffold gap, you should go back and post dilate.
This is less than a scaffold.
Yeah.
Your,
So if you're less than one scaffold width, you can leave it.
let me go back here. Let me show exactly.
So I think
where
that's
we
the important point, because once we do some technology, we have to come up with a clear-cut statement what is allowed, what is not allowed. Because you start going with every strut, you will be just keep post dilating.
Okay, right here.
Yeah.
This is where we thought angiographically was not, expanded.
Although it's a very good lumen. Now, what is the lumen cross-sectional
Okay,
area
so
there?
this is where, you see here?
Millimeter MLA.
At 10 and 11 o'clock position.
Yeah.
Area,
Areas.
okay, MLA.
It's less than 4.
Oh, 3.86.
Good. Good. But that's the less.
that's a-
You expected at least 4.0.
Yeah. Reference is small SS.
Okay.
But if you see your where opposition, well opposed and not opposed, it's still less than a scaffold. You can see the size.
Yeah.
Scaffold.
Less
Less
than
half a
scaffold
scaffold.
width.
That's
tap.
here, right here,
Yeah.
right?
Okay.
Now where do we move it again? Come back here, right there, yeah. But the rest of the area is nicely opposed. Only this part.
Perfect.
You don't
So-
see a lot of calcium.
Anu, here is the real important
Calcium,
question.
yeah.
Almost
Yes.
here.
No, you see the calcium chunk here.
There was here.
Samin, both
Yeah.
for you and Anu, this is the real important question here. Now, if this was a DES, you would post dilate here.
DES we would not have seen it. You see the same area below, which was a Promus, nice expansion,
Yeah.
right at
But
that
you're
spot.
right.
No, no, let's say if
yeah,
you-
you're right.
if you are-
means you can go back and post dilate to
Right.
increase the lumen, minimal lumen cross sectional area. That
And
is
to
correct.
and to oppose it completely, whereas with this you are accepting it as it is,
Right.
because you don't want to disrupt the struts.
But although it is opposed, okay, because we are dilated with a 3.0.
No, let me tell you, let's go back that if with the DES you see this, you will leave it alone also.
Yeah. Okay.
Yeah. Means you have seen the rest of the area, well opposed.
Yeah. Okay. So let's complete our presentation. Before we go on, I want to really show, go back to fluoro. So this is that mini kissing balloon inflation. So just wanted to say once again, you go to the main vessel, same size balloon, high pressure, and then you have a smaller balloon, undersized. In this particular case, we have 2.0. The side branch was 2.5. So 2.0 at 8 atmosphere. So you see that there is still a dent at the ostium of the diagonal. That's okay. Our purpose is just to open the strut little bit, and that strut is going to dissolve shortly in whatever shortly means, as long as there is no acute problem in next 1 year, 2 year, 3 year, and that will really open up the ostium. So with that note, I think we just come to our conclusion with the take-home messages, the BVS in bifurcation lesions and prognostic value of the post-PCI FFR. The absorbed BVS is being used in complex bifurcation lesions with implantation technique different than metal DES. In dedicated two-stent technique, BVS in main vessel and the metal DES in side branch, like in this case we did, is most optimal. Avoid high pressure kissing balloon inflation via absorbed BVS. T-stent technique is recommended when two BVS are used, and avoid BVS crush, because you can imagine how big the metal will be, or the plastic material will be.
Plastic bricks.
Yeah, that if you do a crush. So, two BVS are okay if you are doing a T-stent technique. Everything else, in my opinion, use a metal DES for the side branch. Second point, the recent reports underscore the optimal FFR post PCI, and final FFR of 0.87 to 0.9, which we have spoken, is associated with higher MACE. So, hence stent optimization using IVUS OCT and non-compliant high pressure balloon dilatation or another stent deployment may be needed to optimize FFR post PCI, especially in the diffuse lesions. So, that is very clear cut. So, with the three questions, the following statement false regarding the some published absorbed BVS data for bifurcation lesion compared to metal DES that have equivalent MACE, equivalent device thrombosis, equivalent or higher mortality, equivalent stroke, equivalent BARC 3 to 5 bleeding. Second question, following BVS specific protocol for treatment of bifurcation lesion is recommended except is adequate pre-dilatation and kissing balloon inflation before BVS deployment, BVS in main vessel and DES in side branch, post kissing balloon inflation with up to 0.5 millimeter larger non-compliant balloon at 20 atmosphere, minimal scaffold overlap or protrusion, and full lesion coverage. So, basically is that which one is wrong answer. The third question, in approximately what percent of cases post PCI FFR is less than 0.81 in the reported studies? More than 50%, 40 to 50, 25 to 40, 5 to 25, or less than 5%. All these answers will be on the the archived cases. So, we encourage people to visit our archives and get the subsequent answers.
Excellent, Samin. Anu, take home message from you.
I think whoever is trying to use BVS should not be doing this kind of complex cases in the beginning. I would say just get used to doing simple straightforward cases. Even if it's calcified, try to do single stent cases. Learn how this technology works before you go to this kind of complex case that we just showed.
Samin, final thoughts from you?
Yeah, but I think that we will continue to show, we are poised to teach our viewers how to optimize the BVS use. I know that BVS came with a big excitement 3-4 years ago in the globe, and of course now United States in about a month, and outside the United States enthusiasm of the BVS dropped down largely because of the issue of the scaffold thrombosis, which in my opinion, which have been shown by the data also, is purely technique related. So, we will continue at our CCC live webcast to show the best technology, its optimal use by optimization of the BVS deployment. Then hopefully today's case was one step closer to showing the BVS optimization technique.
Samin, very astute final comments. My personal take home is that not only will we continue to teach you, but I think we'll also learn. These are evolving techniques and we hope to master them at the earliest. I hope the viewers have enjoyed this case, learned many new tricks about BVS. We'll see you in the next session, which is September the 20th. Till then, we'll see you.